speaker is Dr. Brenda Guerrero, and I was asking her, I had used the Hispanic definition or pronunciation of her name, and she says she's Italian, and so as far as she's concerned, it's Guerrero. So Dr. Guerrero is director of the Gerontology Certificate Program at Our Lady of the Lake University here in San Antonio. She's also assistant professor in the undergraduate psychology program there. She has worked with and conducted research on cancer patients and Alzheimer's patients and their families for over 15 years. Dr. Guerrero teaches courses in gerontology, death and dying, grief, and frequently conducts workshops and seminars on these issues. Let me present to you Dr. Guerrero.
Thank you. Well, I'm going to try to use this other mic because normally I'm accused of having a really loud voice. I've had other professors move their classrooms because they couldn't stand being near me. So hopefully my voice will still be loud enough even with this one because I move a lot. The Italian blood keeps me moving and the hands moving, so I don't do very well with these mics. Hopefully when they get back, I can just increase the volume level and stay over top of them for you so that you can continue to hear. Also, I wanted to make one statement in regards to my name and the pronunciation because I didn't want to seem like I was being disrespectful to Hispanics. My husband's Hispanic. I just can't pronounce my name. I don't speak Spanish. I can't pronounce it properly, so I don't attempt to do so. That's probably safer for me. When I was asked to speak about psychosocial issues of dying, I thought, oh my gosh, okay, I can do that in a one-day workshop. And when I realized I had 40 minutes, I thought, oh boy, I need to really whittle this down. And so I gave it some thought, and I thought about what groups previously have wanted me to address in relation to dealing with psychosocial issues surrounding persons who are dying and their family members. And the one thing that always comes to mind for me, it goes way back, I started spending time with people who were dying when I was 13. The summer that I turned 13, my mom was working in a county hospital that had been at one point a TB sanitarium. They didn't have any patients anymore, and so they converted this hospital. And I went to volunteer 40 hours a week that summer. I'd go in and spend the whole day at the facility where my mom worked, and it was a great learning experience for me. They wanted me to stay down on the geriatric ward, and I did spend a lot of time on the geriatric ward, and that's where I fell in love with elders and working with elders. But there was another ward at that hospital that really just drew me, and I ended up spending about 20 hours a week there, and it was a ward where people were sent to die. This was in the early 70s, and we were very much lacking in pain management at that point. And all of these patients had been abandoned both by their physicians, the medical community, as well as their families. So almost no one on that ward had anyone that visited. The staff nurse tried to manage things as well as she could. The nurses' aides did a great job with what they had. They were very understaffed. And so they didn't really mind this kid up on this ward very much because I would go up there and just listen. And I hung out with these folks who were dying, most of whom were dying very difficult deaths. To this day, the most difficult deaths I've ever witnessed. A lot of them were in intractable pain, wasn't being managed, and they were in spiritual and psychological pain because they had been abandoned. And at the time, it didn't seem unusual to me. Just felt natural. Looking back, it was probably unusual for a 13-year-old to be drawn to that sort of setting. But what I realized was that they needed another type of care just as much as they needed the medical care that they were receiving or that they had hoped to receive. And that was the psychosocial spiritual component that was lacking there. And so I spent 20 hours a week just listening to people. And what struck me was the incredible blend of emotions that always surfaced that made everybody else hightail it out. And so I just learned to sit there and be with their emotions. And then years later, when I started getting asked to do a lot of seminars and a lot of workshops by a lot of different medical associations and societies, that was an issue that started popping up. And people said, you know, we've gotten lots of training, but there's this issue that we don't feel real comfortable in dealing with. We don't have a lot of time, for one thing. This is not our job, but the patients and their families want to kind of unload or bring these emotions out at inopportune moments, and we don't want to just ignore this, but we don't have a lot of time. We don't have the training. How do you deal with this stuff? And so I started talking on this topic, and what I'm going to do today, in your handouts, I've given you what's going to be up here is my slides, and I'm not going to focus very much on the specific background of how these emotions come about, but I'm going to focus on the intervention strategies. I've included intervention strategies that are designed for anybody to use, so you don't have to be a trained psychologist, you don't have to be a trained pastoral counselor, you don't have to be a trained social worker. It doesn't matter what your background is. These are interventions that you're going to be able to utilize to assist patients and their families with some of the more difficult emotional challenges that may be presented. And if you look at the title, I realized I don't know where the slide thing is. Okay, so it's the left. Okie doke. If you look at the title, the psychosocial issues of dying. I'm going to focus on managing one's emotions as the psychological component, but one doesn't manage one's emotions while he or she is dying in a vacuum. That takes place in the context of families as well as larger communities. And although everything that I talk about is not going to apply to all people, because families have their unique culture, and then within the families are embedded in their unique cultures. And I know that you heard a talk earlier dealing with some of the cultural variations, and so you already are going to be keeping that in mind. But just kind of as a generalization, these are things that most commonly pop out of the woodwork, come flying through the doors. Over the years, they're the most commonly, challenging emotional situations for professionals that have come to me asking, how do you deal with these things? So the social part comes in the context of all of these will apply not only to the patient, him or herself, but also to the patient's family. And the way that I think about all of these emotions is that they're all part of grief. Because anytime you're dealing with a core level loss, and death is a core level loss, anytime someone is in the process of losing someone or something that is beloved, or has already lost that beloved person or animal or thing, they're going to grieve. They may choose not to do it out here, but it's taking place internally. And so all the emotions that I'm going to talk about are emotions that I couch within the framework of people doing their grief work. The person who is dying is grieving the loss of everything. They are losing everyone as well as everything that they've ever cared about and loved. That's a tremendous amount of letting go. There's a tremendous amount of emotional attachment to all of those things and all of those people that they have to let go of. But the family members and other loved ones are letting go of that person, and at the same time still trying to keep them involved in their life because they are living. And that's a real difficult boundary, sitting on the fence for people to try to stay involved and engaged in this person's life, but yet at the same time trying to let go of them in that life. And so families are dealing with their own difficult emotional issues. When you bring up the issue of elders, people expect that maybe there are a lot of unique situations in relation to helping them process their emotional experience, helping their families to deal with that. I don't find that to be the case. after years and years of working with elderly people as well as younger and elderly dying people, I don't see many differences. And so for the purposes of my talk, I'm not going to make a big distinction throughout. There are a couple issues that are different, and I'll mention those later on. One thing, though, that I did want to mention is that elders typically fear, as do younger people, the process of dying more than the prospect of being dead. So death itself is not nearly as great a fear as the process. And you all know that, and that's true of younger people also. It's a unique situation. My students like to think that the older you get, the more alike you become. And you folks already know that that's not true. And we find there's more and more difference as people grow older. And that is true also of how people are going to experience their dying process from an emotional standpoint, from an emotional perspective. But regardless, you've got to enlist the entire family in helping people process and find ways to work through these emotions. I don't know, I know my audience. I've got doctors and nurses and social workers and pastoral counselors and who am I missing? Psychologists? Pharmacists. I don't know how you were trained, but in my training as a psychologist, both as a developmental psychologist first and then going back and retraining as a counseling psychologist, we were trained that really strong emotions that are difficult for people, that cause them distress, need to be changed, gotten rid of a lot of times. So if somebody's depressed, you need to lift them up, right? And if somebody's anxious, you need to calm them down. Don't we always do that? Oh my gosh, they're bouncing off the wall. We got to give them something to calm them down, or we got to talk them down, or whatever. And I've learned that no, that's exactly what we shouldn't be doing. What we need to do is to help people feel those emotions even more fully instead of shutting them down. There's a wonderful grief therapist by the name of Ken Moses. I don't know if any of you have ever heard of Ken, but he talks about how there's this saying that we need to make our patients feel good, with the emphasis on good. You know, we always want to make everybody better, make them feel great, you know, take their pain away, take their sorrow away. And he said the emphasis is on the wrong word, that the emphasis should be on feel, that we should make them feel better rather than make them feel better, if you get that. I agree. These are the emotions that I'm going to talk to you about. The first one is always a biggie in psychology because we're often trained, and I know a lot of social workers have been trained this way, although some of you haven't been, that denial is something that's bad and you need to get rid of it. And so if you break some bad news to the patient and they don't want to deal with it, well then you got to make them understand so that they can make effective, choices. They're being obstructionistic, or they're being difficult, or crazy, or whatever, bad. I believe, I've only ever seen one patient whose denial really became very destructive. Other than that, it's always been a positive thing. It helps them to buy time to deal with whatever they have to deal with. And so the challenge for us becomes, well, how do we help people to hold on to that if that's where they need to be at that point? Because like I said before, nobody's ever really prepared for a core level loss. How do you prepare for the death, the ending of yourself? I mean, we can do that on a theoretical level. We've all done it. But I don't know how many of you in here have ever been given a diagnosis of a fatal illness. And you're either living with it now, longer than you were supposed to, or they made a mistake. I haven't been given such a diagnosis, but I've known many people who have, and some who ended up being just fine, and some who weren't. But the point is, when they were given that information, none of them could wrap their mind and heart around that 100% right away. It's too much. There's a video that I show in my Death, Dying, and Grief class that deals with hospice. And there's a nurse in this video that says, looking at your death, your mortality, right in the face is like looking at the sun. You have to look away. You can't continue to look directly at the sun, and you can't continue to look directly at your own mortality, at least early on, until you've had time to adjust. And so I say, help people hold on to that denial. It helps them buy time to find the strength that they're going to need to do the work that they're going to need to do. So, what can we do to help? Just ease them into it. One thing that I find, particularly my beginning counseling students, what they want to do, not necessarily people who are dying, but just when anybody is dealing with the issue of denial, they want to just confront it. They want it to, be kind of argued out logically. Well, you've got to look at this logically. You've got to look at this realistically. And I found that logic has no basis here and that it's not helpful. And so, personally, what I do is not confront denial. I don't ever confront it because it puts the person on the defensive. And you want to be their ally. You want to be someone that they can feel comfortable in sharing whatever they need to share. And so if you're trying to shake them out of it in whatever manner you feel comfortable with, they're going to shut down around you. Engage the person with the person's feelings, not the content. And what I mean there is that whatever the person is saying, regarding the context, the situation that you're dealing with, that's the content. Whatever the words are, whatever they're saying that you want to counter. Forget about the message and go to their feelings. You will always get farther if you engage them at the level of their emotions, at the level of their feelings. Boy, this must be really very overwhelming. Or if you don't even want to imagine that you know that much about how they're feeling, boy, a lot of patients that have been given news like you've been given, or boy, a lot of patients who have been through the treatment regimen that you've been through find it really, really difficult. So they may be sharing how they feel or not, but you can always engage them in some way. I find that the only time somebody really needs a referral to a psychologist, for example, or a social worker to deal with denial is if it is really interfering with that person's life. I worked a long time ago with a woman with breast cancer and she really just shut it out. I've never seen anything like this. She shut this breast cancer out, and she refused to go to a physician, and she ended up, at the point at which I started working with her, about 3/4 of her breast tissue was just gone. And it was open and seeping, and it smelled a lot, and everybody else could tell that something was going on. And she really just blocked it out. And that was her way of dealing with it. That was destructive. That was not denial that was working in this woman's favor. But that's a really extreme example. I've never seen anyone else deny to that extent. So for the most part, I think it's perfectly normal, and we need to just help support people in their denial. Now, anxiety usually follows denial. What I didn't mention when you look at that slide with the list of emotions, denial and anxiety, the first two are preparatory. They prepare patients and family members to deal with a road ahead of them that's going to become even more challenging and more difficult. And so anxiety and denial tend to get clumped together in most people. It's rare to have somebody that is experiencing denial that's not feeling some anxiety. Anxiety is related to the situation that they're currently dealing with, but anxiety also pushes that little red button that reawakens a lot of other previous losses, issues that are unresolved. And so a lot of times you wind up dealing with the present and the past, as well as the future that's going to come into the picture when you're dealing with this. Anxiety, again, should be looked on positively. Anxiety provides an incredible amount of emotional energy that patients and their families need. Now, it can get out of control, but normal anxiety is to be expected when someone is dealing with the issue of their impending death, as well as the family losing that person and dealing with their own losses. And so I think again, you need to look at this as very healthy, as very normal. Dying's the big unknown for all of us. Even if we have very certain expectations about the afterlife, we've none done it, unless you've had a near-death experience. So for most of us, it's very unfamiliar, and that naturally raises anxiety in people. So from that perspective, normally it's not going to be a problem. However, it can lead to panic attacks. If that starts to occur, then you do need to take a more active stance in terms of intervention, and I can talk about that a little bit for anybody who'd like me to later. But you need to think about what anxiety represents. Think about that, because a lot of times we clump anxiety, panic, and fear together. Anxiety and fear are real different things, because fear is directed. If you are fearful of something, there is someone or something that fear is directed at specifically. However, with anxiety, it's a more free-floating sort of apprehension that you feel in the absence of a specific thing that you fear. That makes it challenging to deal with in one respect. Because if you just have this free-floating anxiety that's just kind of out there, and it's not targeted at any particular thing or person, then it's more difficult to help the person address that issue, to alleviate the anxiety, because it's not as directed. So what I help people to do when they're really dealing with a lot of anxiety, if it's a problem for them, if it's not a problem for them, then it's not a problem for me. But if it's a problem for them and they want help with that, then one of the easiest things I've found to do, and it'll take 5 or 10 minutes, help them to break it down. So it's not just anxiety. What specifically are they anxious about? So help them to break down and identify specific fears. Sorry, forgot to flip that for you. So you can then address specific things individually. That's much more easily handled than dealing with just this big free-floating anxiety out there. One of the other things, and this will come up again, the providing information. It's a big issue with anger, it's a big issue with fear, and it's a big issue with anxiety. Patients report feeling all of those emotions in relation to a lack of information. So anytime you can provide information to the patient as well as the patient's family regarding whatever their particular fears or anxieties are about, that may be what to expect physically. You know, what is the physiological process that this person's going to have to deal with respect to their dying? Their families want to know that information also. What about spiritual issues? I've dealt with some people real tormented at the end of life in relation to spiritual issues that were unresolved. I don't have those answers, but I went and got them a priest or a minister or whichever type of religious person they needed to help them gain the information that they needed to help start to sort through those emotions. So it may just be a referral that they need to someone else that can provide information, but a lot of times patients are afraid to ask. They have big unanswered questions and they won't ask because they're afraid to. They think, oh, it'll upset this person, or it's going to take too much time. They're always so busy. They have all of these other patients to deal with. Or they have tried in the past and someone else shut them down, and so now they're afraid to try again. And so you can easily just probe, are there any questions you have about this particular form of therapy? Or, are there concerns or questions that you would like me to answer for you now that all aggressive treatment has stopped? Are there questions that you have about hospice? Whatever it might be. They may not initiate it. Okay, but if you can try to put yourself in that position, certain questions will automatically come to mind that the average person would have in relation to that particular issue. One thing that I find to be really, really helpful is to teach relaxation and or visualization, guided imagery. I've got friends who do a lot of hypnosis with patients who are terminally ill. I don't do hypnosis, I just do guided imagery and relaxation and visualization. But even if you don't do that, there are lots of people out there that do. And so refer the person or recommend some of the tapes. If you go to Barnes & Noble or any of the bookstores, they have a huge section on guided imagery and visualization and relaxation. They actually even have tapes specific to about every disease known to mankind. So they've got them for lupus, they've got them for cancer, for AIDS, for kidney disease, for a lot of specific disease processes that people might be dealing with, that they kind of alter the visualizations for their needs. And so if you don't feel comfortable with it, you can ask the person, have you ever tried relaxation strategies? Have you ever tried visualizations? Well, no. Well, are you receptive to that? Sure. Well, would you like me to refer you to somebody that can help you learn those techniques? Or would you like to just try an audio cassette and then tell them how to go about getting one of those? That can be really, really helpful. What you don't want to do is try to calm the person down. And that's usually the first thing that people try to do when they've got a patient that's very anxious. Everybody's tried to calm the person down. You're just going to be one more person that's not giving them what they really need. And so you don't want to try to calm the anxiety. You don't want to take their anxiety away from them. They're viewing whatever their issues are as very important, and you can look at it as condescending in a sense to just shut them down, to poo-poo away whatever their issues are by trying to just shut them down and calm them down. And so I encourage it. I want to bring it out. I want to find out what's causing this. And if they start to talk about something, then again, engage them with how they're feeling. Oh my gosh. Oh, now that you tell me that, I can understand. You must just be crawling out of your skin. Is there anything else you'd want to share with me about that? And you've just given them an open invitation. And so they may say, okay, the door's open. I can at least talk to this person about it. Okay, so just don't try to shut them down necessarily. Another thing that's real helpful with anxiety as well as with anger and fear, and I'll talk about this, encourage physical outlets. Now, I understand for a lot of people who are dying, they may not have the physical energy to release anxiety in some sort of physical manner. This becomes especially important, however, for their family members. And in whatever way that person could express themselves physically, the person who is dying, then encourage them to do so if they can. If they can't, then that's an avenue that you can explore with their family members, okay, to encourage that physical release. Some of these emotions tend to have a real strong physiological component, particularly anger. And the more they can release physically, the easier it's going to be for them to let go of some of that emotion. Second strategy there is a cognitive behavioral thing. Identify negative self-talk and teach coping statements. All of us, you guys can relate to this in your own life. Stop and think about something that you have beat yourself, over the head with the wet noodle about because you just didn't do it well enough. And I should have been able to save this patient, or I should have been able to protect my kid from falling off his bike and knocking his front teeth out, or, I should be able to be super mom and super wife and super doctor or nurse or whatever. Right? You all have your shoulds in mind? Yes? You've all done that? Or are you all superhuman? You don't do that. I do that. I catch myself. I should have done this, or I should be able to do this, or, I ought to do this, or you should not have done this. That's another biggie with families. Oh, if I had just not said that, or, oh, if I had just not done that, maybe they wouldn't have, had this bad turnaround. People always have the what ifs. You need to identify those. Help people, because everybody's got them. Help the person identify what their negative self-talk is. I can't get through this process, or I can't do this, I can't do that. Find out what is very self-defeating in terms of the messages that's running through this person's mind, and then help them to learn more positive self-talk. I can't do this. Well, this is really challenging for me, and I'm going to give it the best shot that I can. That's much more positive than I just can't do this, because they don't know if they can do it. But this is really hard, and I'm going to try. And that's just one example. You can get into a lot of different types of coping statements, but that'll give you an idea at least. A lot of people get very tied up with their physical reaction. Any of you who have ever had high anxiety in a situation, or maybe even somebody's gotten close to panic attacks, or you've actually had them? It's hard for me to see you out there. I'm looking for head nods. How do you feel? I mean, when you have the physical sensation of that anxiety, you don't like it much, do you? So it's unnatural to just go with the flow. When you feel that way, what's natural is for us to want to get rid of it. But if you can help the person explore the physical sensations, to stay with it, you know, people do that in pain management all the time. Help the person to just accept, this is not good, it's not bad, it just is. This is the way my body is feeling right now. Observe it, but more from a detached sort of standpoint. This isn't a bad thing, this is just the way it is right now. And then if they can learn some form of relaxation, they'll be really in a much better position to notice the difference. And that is really empowering. When a patient can feel the difference between this really tensed, uptight sort of bodily sensation and the opposite of that, or at least movement in the opposite direction, that becomes very empowering. Has anybody in here learned biofeedback? None of you have ever gone through biofeedback for pain management or? No. A couple. For headaches, migraine sufferers in here? Works really well. Okay, so 2 of you have learned biofeedback. Wasn't that incredibly empowering for you? Yeah, and so patients don't need to learn biofeedback. They can learn very subtle control over how they respond to some of their bodily reactions, and that can be incredibly powerful for them. So we always talk about how can you find ways to help this person maintain some control. They can have that little bit of control in that arena. Another thing, this kind of, you might be looking at this thinking, oh, that seems really strange, I wonder what she's talking about. If they have panic, express anger, that may sound strange. However, if there are any psychologists out in the audience, you know that panic is associated with panic attacks also. Panic and anger are incompatible emotions. So if somebody's having panic attacks, which become very serious, and that becomes real problematic, and that can be real common in family members. It's very common when people are grieving. And it can be very common when people are undergoing anticipatory grieving, not just grieving after someone's death. If you can help the person to release the anger that's underneath that, it pushes the panic aside, and it's actually healthier to get that anger out anyway. Now, you don't want to turn somebody into a rageaholic, and that's not going to happen anyway. But a lot of times, if you can get to the underlying anger, the panic will start to subside. And they're not going to both occur concurrently, which may help at least deal with the panic at the moment. Guilt is a biggie. And there's a lot of different types of patient guilt. There's a lot of different types of guilt that the family experiences. I listed just a couple on the slides. There are others. I could have a much longer list, but basically you got to look at what the underlying issue is. People feel guilty because they're trying to make sense out of their world. They're assigning cause to things. Oh, if I had just not been running late, then my husband wouldn't have been at that intersection at that moment and he wouldn't have gotten killed. What's somebody doing there? They're feeling guilty because of a behavior that they did or did not do. But why are they doing it? They're trying to make sense out of what happened. And it doesn't matter really if you think it makes any sense at all. Doesn't matter. Because a lot of times people's guilt is very individual to them, and you're not going to make sense out of it, but it makes perfect sense to them. And as I mentioned before with one of the other emotions, you don't want to try to talk them out of it. Because you've all experienced this probably. You felt guilty about something and people tried to talk you out of it. Oh, come on, it wasn't your fault. How did you feel when someone did that to you? Anybody? How'd you feel?
Well, I think it's
Yeah, you just don't know. And so were you getting a little frustrated, a little angry, a little indignant? Sure, you've all been there. I've been there. That really pushes your button. You get real fed up with people because they're just not hearing you. They're not understanding you. They're belittling what your experience is. And so don't try to talk them out of it. Don't try to make sense out of it necessarily. But again, try to engage them at the level of their feelings. And you can do that for these different types of patient guilt, for different types of family guilt. The top one is a biggie. Guilt over feeling a lot of different things. They love this person who's dying. They want only the best for this person. They'd also really love it if this person would just hurry up and die. And 50 other things that's running through their head at the same time that can cause a lot of confusion and a lot of guilt because, oh my gosh, how could I be thinking that? As well as, if only, or role guilt. If I were a better father, I'd be able to protect my child from this. I could have kept this from happening. Guilt over not being ready to let somebody die or abandoning the person before it's time. So there's all sorts of guilt. Encourage expression of it. Normalize it. Normalization of all of these emotions will go a long way. Most people just want to be heard. There's nothing you've really got to do. You can't take their emotions away from them. You can't fix it and make it all better. They need to be heard. What they're feeling needs to be embraced. And what that involves is normalization. But what I find, particularly with some of my beginning students, is that they think normalization is just to kind of like, oh, well, this happens to everybody. That sort of thing, which minimizes it. And so you need to be careful. You want to normalize it so that people realize, well, this isn't something that I'm the only person on earth who's ever, felt. It's something that a lot of people in similar situations have dealt with, and it is very challenging and it is very difficult, but there are ways that you can work through this emotion. There are ways that you can learn to deal with this. It provides comfort. People are afraid of losing control. When they start to feel these very strong emotions and they don't know what to do with them, they think they're going crazy. They think they're going to lose control. They think they're never going to be able to get it together. They think they're going to just hit meltdown and stay there. And so if you can normalize the emotions to let them know this is, part of this and it's okay. It's okay for you to feel this. It's okay to experience it. That can go a long way in helping them to feel a little less crazy about it. I've had people tell me, oh my gosh, I can't tell you how good it is just to know that I'm not the only person that's ever felt this because I thought I was losing it. I thought I was going crazy. And that doesn't necessarily make it more pleasant to feel what they're feeling, but at least they don't have to worry about going crazy on top of feeling that way. So that can be real helpful. Also, another thing is that people tend to focus on the negatives. They're feeling guilty because they didn't do this or they didn't do that. And if you can help them look at their relationship, if this is the dying person, help them look at their relationships with their loved ones. If it's the family, help them look at the relationship more realistically with the person who's dying, to integrate the positives as well as the negatives, because the more they can start to embrace the positive memories that they have of that relationship, the more difficult it's going to be to continue to hang on to the guilt. Okay, because they weren't so awful. They weren't the worst daughter in the world. Look at all these wonderful things that took place in the context of the relationship with their mother. And so if you can start to bring that up, it's what we do when we do reminiscence with older people. Okay. Try to identify and reduce self-punishment. People will punish themselves a lot. Some of these things, I'm running short on time, so I won't be able to go into all of them. If you have more questions, feel free to email me. Setting a date, role taking, these things sound somewhat ineffective, I guess, to some people. But what I mean there is either, like with role taking, I've had patients say, okay, for a week I'm going to act like I'm not guilty. Doesn't sound like it's going to do anything. It does. If they can actually pretend to be not guilty, then they can see that they can actually find freedom from it. Or setting a date. I'll have people set a date. okay, by August 21st, I'm going to be done with this. And so I'm going to do it head first until then, and then I'm going to let go of it. I don't know why it works. I just know that it does for a lot of people. Self-forgiveness, support groups can be very helpful. With depression, if you look at the literature out there on dying people, a large percentage of people who are dying experience depression. It's normal. It's to be expected. It's also adaptive. It's also normal for their families to feel that. Doesn't necessarily mean that they are clinically depressed. And so what do you do to intervene? Again, try to normalize the feelings, encourage them to express what they're feeling. You can also help them to reframe their cognitions. So if they're saying things like, I'm always losing control, I'm afraid I'm going to break down. Those are real negative ways of thinking about what they're experiencing. You can help them think about it in terms of, like instead of the losing control, they're experiencing an emotional release. Yes, it's just a change in terminology, but it also changes the way that people are thinking about it. Or intense feelings rather than being out of control. It's easier for people to deal with a lot of times. Let's move on. Anger. That's a biggie. I have therapist friends who say they would be out of business if it weren't for mismanaged anger. So it's not just in people who are dying or their families. Most of us did not learn how to deal with anger very effectively. Our role models, our parents, taught us frequently to either explode or to do the opposite, which is shut down and smile and say, I'm not mad, I'm fine. And so what happens when our patients blow up at us or their family bites our head off? We have trouble dealing with it because we have trouble dealing with anger, period. Guilt and anger frequently become intertwined. It scares the heck out of people. There's lots of different sources of anger, but how do you deal with it? Again, normalize it. Give them permission. Help them to get it out. Most people want to shut them down. I help people get it out. And to help them understand that, I don't know how many of you are familiar with Barbara DeAngelis, the love lady. Yeah, she talks about this kind of triangle in terms of expressing emotions, and anger's at the top, like in the context of an intimate relationship, if it's with your lover, your spouse, your child, whatever. Then a lot of times we blow up at them, oh, you're a jerk, you're so bad, and da-da-da-da-da. The anger comes out. But she goes on to show this diagram of all these other levels of emotions underneath the anger. Fear, sadness, hurt, all these things, remorse. What it boils down to is those are much more vulnerable feelings for us to have. Almost all of us are more comfortable expressing anger when we are really hurt or really scared because we're not as vulnerable then. And so a lot of times educating people about their emotions can prove to be real helpful. Fear. This was already brought up in the last talk. What are two of the big fears? Abandonment and pain. There's others there. What do you do with fear? Same things you do with anxiety. And so in relation to time here, I won't go into a lot of detail there, but there's one last thing that becomes real common, I think, more with elders than with younger people who are seriously ill, and that's loneliness. Maybe a lot of their loved ones have died. They don't have as many people around them physically in their social network. They may also feel really internally isolated and in consequence lonely. I find that doing life review, and I don't do this just with elders, I do it with younger people also, works really well with middle-aged people. I do a life review to help them kind of get more connected with them looking at maybe what they haven't accomplished or the negative things, to integrate it with the positive things. And I also help people to build their social network if they need to do that. And there are some other things that you can do in relation to that. But just in general, I think there's some points that have been mentioned. I want to share a story with you real quickly in the last 3 minutes. And it's a story about a woman that I was called to work with. It has to do with making contact touching, being present, not necessarily having all the answers, being a good listener. A nursing home administrator called me on the phone. I was at work in my office, and she said, Brenda, there's a patient here in the nursing home, an elderly nun. She's in her mid-80s. She said cancer for a long time, she's been in denial. She never really acknowledged that she was going to die. Well, she's really physically dying now, and she just won't let go. And there have been about 250 people in to visit her in the last couple weeks, and nobody can help this woman die. And she's starving herself. She won't eat anymore. And the list goes on. I said, well, geez, I think she's just dying. She's not starving herself, trying to get back at you. She doesn't need food, probably. And, are you sure, what, is it really the problem that you're making out? Yeah, nobody can help. And I said, well, geez, I'm real sorry to hear that. And she said, well, can you come? And I said, well, I don't know her. If 250 other people have been there, all these religious people, and they haven't been able to help, I probably can't do much. And she said, no, you got to come. And so I said, okay, I'll come. So off to the nursing home I went. And I walk into this room, and there's this little, very petite, very kind of tightly pulled in lady laying there. And I knew something was wrong the minute I walked into the room. I had no idea what. I just knew something was wrong. And so they kind of pushed me in, pulled the door shut, put a do not disturb sign on the door, and just left me there. So I introduced myself, and while I was talking with her, I had just kind of gently laid my hand on top of her hand, and I was stroking her hand. And I had no agenda. Everybody else had an agenda with her. I didn't know what I was doing. I said, well, sister, this is who I am, and so had me come talk to you, because she's a little worried about you, and I'm just rubbing her hand. And she says, oh. And I'm thinking, okay, I'm just going to do nothing, which is usually what helps. I'm just going to be present, and I'm still rubbing her hand because I'm a real believer in touch. And finally, I thought, okay, maybe a back rub. So I said, sister, would you like a back rub? I bet you haven't had one for a long time. And she said, oh, yeah. So I said, okay, let me go get some lotion from the nurse's station. So I opened the door and I went out to the nurse's station. They were like, oh, you did it. And I said, no, I need some lotion. And they said, oh, here, and go back in and do your job now. And so I took the lotion back in, and I went up, and I was, rubbing her hand and started rubbing her forearm a little bit. And I said, well, sister, whenever you think you're ready, do you think the two of us can get you rolled over enough so that, I can rub your back? And she looked up at me. She just stopped, and she looked up. I still am doing this. And she says, are you Catholic? And I thought, oh, God. Do I lie to a nun? And then I thought, no, I can't lie to this woman. And so I said, well, no, sister, and I'm still going like this. I said, no, sister, I'm not Catholic. Does that make a difference? And she looked up at me and she said, well, since you brought up the issue of sex, I guess we can talk about it. And I'm really rubbing. I was thinking, oh, whoa, what did I just do here? And I said, okay, sister, what would you like to talk about regarding sex? And she went on to share with me a story that she had never shared in her 80-some years. She had had an incestuous relationship with her brother when she was a child. And one of her greatest fears, talking about fear, was the fear of burning in eternal hell. She had never even confessed to this. She never told anybody. That's why she couldn't let go. And so I tried to normalize, tried to help her to share the guilt, the fear, to explore what her specific fears were, to help her share how she had shoved it down and not dealt with it, denial, the depression that she felt at this point in her life because she had been so bad. In her mind, everything she had done, giving her life to the Lord and helping serve mankind didn't mean anything. She was just bad. So I helped her just release all of that in a non-judgmental way. And then I got her a priest that she didn't know, because I knew the priest that she knew, and he would have made her feel worse. And so I got her a priest that she didn't know and that would not be judgmental. And about 2 hours after she confessed to the priest, she died. And that was a real powerful learning experience for me. One, because it integrates all of this stuff. I didn't do anything. 250 other people had been in there trying to help the woman die. They were pushing too hard. It was just my presence, I'm convinced my touch, and the nuns that I work with would tell me, also because I wasn't Catholic, that she was able to share that. And so even though I didn't have time to go into a lot of detail in a lot of these issues, know that you all have the capacity to help the families as well as the patients deal with any of these emotions. Because if you know going into the situation that there's nothing you can do to take it away, and that you wouldn't want to anyway, and that really your presence and your openness is what's going to help them process that, then you've all got all of the training that you could possibly need. If you would like to follow up with anything, though, please feel free to contact me, and I'd be happy to provide you more information. Are there questions? No? Okay, then thank you.